trial. Let me just share my screen. Okay, so over. All right, so yes, so I'm essentially a professor of psychological therapist in the Division of Psychiatry at UCL. I'm also an honorary clinical psychologist in a community mental health team for older people at North London Foundation Trust. And so I'm going to be talking about some of the work that we've been doing for a number of years now on a form of psychological therapy for older people with treatment-resistant GAD. So I'm going to be discussing a number of things today. I'm going to be briefly talking about what generalised anxiety disorder or GAD is and how it particularly presents in older people. I'm going to briefly talk about what acceptance and commitment therapy is. Sorry, if you can see a fly kind of sort of buzzing around, then just ignore that. I'm then going to talk about the factoid study, which essentially looks at ACT for older people with treatment-resistant GAD. And then I'm going to talk about the CONTACT-GAD trial, which is basically the clinical trial that we're currently running that's exploring ACT for this population more. And I'm then going to finish just by highlighting a few resources that you can look at in case you're interested in finding out about any of this stuff. Okay, so just starting off then, so what is generalised anxiety disorder or GAD? So essentially GAD is characterised by excessive worry and anxiety that's perceived as being difficult to control, and it's associated with a range of symptoms, including things like feeling on edge, fatigue and irritability. And in order to be diagnosed with GAD, you need to have these symptoms occurring on more days than not for at least 6 months, and for it to be kind of causing clinically significant distress or impairment in functioning. In terms of how GAD presents in older people, so GAD is the most common anxiety disorder in older people, with prevalence rates of about 11%. But these rates are likely to be an underestimate, because we know that GAD is often frequently sort of misdiagnosed as depression with anxiety, or mixed anxiety and depression, or it's just the fact that it's not recognised by the older person themselves. So, for example, people might sort of see it as part of their personality. So you often hear people describing themselves as having always been a worrier, for example. And the underestimate might also be because there are some kind of small differences in how GAD presents in older people compared to younger people, for example. So in older people, they tend to present more frequently with somatic symptoms such as dizziness, shaking and stomach pain, rather than, say, for example, worry. And also older people might describe worry differently, threats, concerns, those kind of things, rather than sort of describing these as worries. Comorbidity with other psychiatric disorders is common, so with other anxiety disorders, with mood disorders, depression, and also with personality disorders. And we know that GAD in older people is associated with a range of negative outcomes, including things like poorer quality of life, increased healthcare utilisation, and increased disability. And those outcomes are even poorer if psychiatric comorbidity is present. In terms of how GAD's managed, so the UK NICE clinical guidelines recommend that stepped care approach to the management of GAD, so ranging from identification and education in step 1, low intensity psychological interventions such as guided self-help CBT in step 2, medications such as antidepressants or psychological therapies such as CBT or applied relaxation in step 3, and then treatment within specialist services in step 4. But unfortunately, we know that some people experience GAD that just doesn't improve adequately with currently available treatments. So, you know, what we call treatment-resistant GAD. In terms of what we mean by treatment-resistant GAD, so there's actually no set definition of treatment-resistant GAD in older people. So there was a study last year that was published by Domschke et al. And they conducted a Delphi study in order to be able to kind of sort of reach a consensus agreement on how to define treatment-resistant anxiety disorders. But this was limited to working age people. So these are the recommendations they made there. But they noted that these criteria, they remain to be established for older people. So we've kind of defined this. So as I mentioned, we've been doing this work for quite a while, so we've had to define it at various different points. So but we've defined this, certainly for the more recent clinical trial, as GAD that's failed to respond adequately to kind of treatment within step 3 of the step care approach, so things like pharmacotherapy and that individual psychological therapy. In terms of management of treatment-resistant GAD in older people, unfortunately, there's a lack of evidence to be able to suggest how this should be managed. And so that's kind of sort of why we've been doing this work. This is originally put out a commission call by the NIHR, and in recognition of the fact that there is this lack of evidence to suggest how to manage treatment-resistant GAD in older people. So one form of psychological therapy that might be particularly suitable for older people with treatment-resistant GAD is acceptance and commitment therapy, or ACT, as we like to shorten it. And ACT is what we call a third wave psychological therapy. And so just to put this in context, the first wave of psychological therapies, things like behavioural therapy, very much focus on changing our behaviour. The second wave of psychological therapies, things like more conventional cognitive behaviour therapy, focused on changing the content, the form, or the frequency of our thoughts and our feelings, kind of sort of how we're thinking and feeling and how often these things occur. And in contrast, the third wave of psychological therapies are really focused on changing how we relate to our thoughts and feelings rather than trying to change the thoughts and feelings themselves. So it's kind of focused on changing our relationship with our thoughts and feelings. And ACT is one of these third wave therapies. So ACT is what we call an acceptance-based behaviour therapy, and it uses a combination of mindfulness and acceptance-based strategies in conjunction with motivation and behaviour change strategies to help people to do one of two things. To help people to clarify the things that are really important and matter to them, what they want to be doing, the type of person they want to be, the things they really value and care about. And the second thing is to help people to learn a set of skills for handling the difficult thoughts, feelings, sensations, etc., that kind of get in the way of the stuff that they really care about. Now, an important point about ACT is that it's not aimed at symptomatic reduction, although we do see that happening in therapy. Instead, it's aimed at helping people to live their lives in ways that are important and meaningful to them, alongside whatever difficult thoughts, feelings they might be experiencing that are kind of sort of outside of their control. And so in the context of treatment-resistant GAD, it's aimed at really helping to let people people to let go of the struggle with the worry and the anxiety, and instead focus their energy on doing the things and acting in ways that make their lives meaningful. So how does ACT help people to let go of that struggle with trying to get rid of the worry and the anxiety, and instead focus on energy on doing things and acting in ways that make their lives meaningful? It does this by helping people to develop this sort of a set of core skills, and it does this through a variety of experiential exercises and metaphors. And I'm just going to briefly take you through a few of these now. So ACT involves helping people to learn skills for clarifying what they really value and care about. So what they want to be doing, the type of person they want to be, how they want to be acting, alongside things like the worry and the anxiety. And an example exercise that we use certainly in the CONTACT-GAD trial, is the Lifetime Achievement Award exercise. And this exercise essentially invites people to imagine that they're being presented with a Lifetime Achievement Award, and the person they're closest to is going to be giving a speech about them, it's kind of sort of describing the things they've done, the type of person they are, and the type of person they want to be. And it really invites them to reflect on sort of 3 to 4 things that they would like the person to say about them in different areas of their life. So, for example, a loving partner, being a caring grandmother. ACT involves helping people to learn skills for opening up and making space for things like the worrying thoughts and the anxious feelings, rather than struggling, fighting with it, rather than trying to control it or push it away. And an example exercise for helping people to let go of that struggle with the worry and the anxiety and opening up to these worrying thoughts and anxious feelings instead is the Passengers in the Bus exercise. And this exercise asks people to imagine they're the driver of a bus, and that things like the worry and the anxiety are the passengers. And it asks them to imagine 3 different scenarios, and to kind of actually practice 3 different scenarios. So shouting at the passengers, so the worry and the anxiety, giving into the passengers, so giving into what their mind is telling them in relation to the worry and anxiety, and then just allowing the passengers, the worry and anxiety, just come along for the ride in order that they can drive that bus in the direction of the things they really value and care about. So that sense of helping them to do the things and act in ways that make their life meaningful alongside the worry and the anxiety. ACT involves helping people to learn skills for stepping back from worrying or anxious thoughts, images, memories, and really to help them to see them for what they are, just thoughts, just images. So rather than sort of buying into them, kind of getting all caught up in them, treating them as if they're the literal truth. It also involves helping people to learn skills for holding the labels that they give themselves, that we all give ourselves, lightly. So labels such as "I'm a born worrier." We all kind of sort of tell these stories about ourselves. We have these old familiar ways of describing ourselves, and sometimes these labels or these self-stories can act like blinkers on a horse, and they can kind of keep us stuck in a rut. Not doing the things that we really value and care about. So ACT involves learning skills to help people to hold those kind of labels lightly rather than holding onto them tightly such they dominate behaviour. And an example exercise for stepping back from worrying or anxious thoughts, images and memories is the I'm noticing I'm having exercise. So basically whenever things like worrying or anxious thoughts, images, memories arise, people are invited to just put, I notice I'm having the thought, or I notice I'm having the image, the memory, in front of it, and then describing the actual thought, image, or memory, as a means of helping people to just take that step back and just see it for what it is. An example of exercise for helping people to step back from those labels, those kind of sort of those old familiar ways of describing ourselves, is the labels exercise, and invites people to kind of just notice the labels that they might give themselves or that other people give them, and to notice whether these labels are working for them, whether they're helping them to do what they want to do, be the type of person they want to be alongside the worry and anxiety, and essentially to hold those labels lightly if actually they're not working for them. ACT involves helping people to learn skills for connecting with the present moment rather than being stuck in their head worrying about the future or ruminating about the past. And so an example exercise for that is the Notice 5 Things exercise. So notice 5 things you can see, 3 or 4 things you can hear, 5 things you can feel in or around the body. So essentially being able to use the senses as an anchor to bring you back into the present moment, rather than being caught up in the past or the future as conceptualised by your environment. And finally, ACT involves helping people to learn skills for taking action, to do the things that they really value and care about, do what they want to do, be the type of person they want to be, alongside that worry and anxiety. So an example exercise for this is the Doing What Matters plan. And so this essentially invites people to identify a goal they want to achieve, as well as what we call the values underlying that goal. So the kind of what makes that goal important to them. So helping them to really connect their goals to their underlying values. Invites people to identify the potential barriers that might get in the way of them achieving that goal. And so we think about the barriers in terms of those external barriers. So things like physical health difficulties, or lack of social support, or lack of money or time. So those external barriers that might get in the way. And then we also think about those internal barriers, the thoughts, images, memories, emotions, sensations, so worrying, anxious thoughts and feelings that might kind of sort of get in the way. We then invite them to think about, to identify ways of overcoming those barriers. So, for example, by using what we call selection, optimization, and compensation principles to help overcome some of those external barriers, such as physical health difficulties. And selection, optimization, compensation principles, these are strategies, they're a bit like kind of sort of problem-solving strategies. They were developed back in the 1990s by Bolters et al. And they were designed to help people to adapt to successful aging, and so they can be similarly applied here. And then we can help people to use some of the ACT core skills to be able to handle the internal barriers, so the acceptance, the diffusion, and the present moment awareness skills that I talked about earlier. And then invite people to kind of consider the smallest thing that they can do that would help them to move towards that goal. And an example of the Doing What Matters plan is listed here. So that's ACT in a nutshell. In terms of why we thought that ACT might be particularly suitable for older people treatment-resistant GAD, so there are a number of reasons why we thought this might be the case. First, there's evidence that control-orientated strategies, such as trying to eliminate problems that can't be solved, that can actually increase the risk of depression in older people. We know from some of the studies in working age people that ACT is as effective as other psychological therapies, such as conventional CBT and applied relaxation for GAD. And we also know that a very, very small RCT of ACT versus CBT in older people with GAD found that ACT was as effective as CBT, but it had advantages in terms of things like higher completion rates. But this last study, it wasn't specifically focused on treatment-resistant GAD, and so that's what we aim to explore in the factoid study. So this was a 3-phase study that was funded by the NIHR HTA programme. We used the MRC framework for developing and evaluating complex interventions to develop a psychological intervention based on ACT, tailored to the needs of older people with treatment-resistant GAD. So we started off by conducting a series of qualitative interviews and a focus group with older people with treatment-resistant GAD, healthcare professionals, and also academic clinicians. And essentially we wanted to kind of sort of explore what a psychological intervention for this population should look like and how we should adapt ACT to meet their needs. We then used those findings to develop an intervention that was based on ACT, tailored to the needs of older people. And we optimised that intervention through further interviews and consultation with our older people with treatment-resistant GAD, with our public involvement group, and with healthcare professionals. In terms of how we adapted ACT to meet the needs of older people with treatment-resistant GAD, I've just got a few examples listed here. So in terms of those ACT core skills that I took you through earlier, As I mentioned, we integrated those principles of selection, optimization, and compensation into our values-based goal setting. These, as I mentioned, they were originally developed to aid kind of successful adaptation to aging, and so can similarly be applied here to help with things like physical health difficulties. In terms of adaptations for cognitive, so kind of mild cognitive difficulties, we used, well, as you saw, ACT uses a lot of experiential exercises and metaphors, and so as much as possible, we used experiential exercises and metaphors that was concrete as possible, and we used visual and physical props and acting out of metaphors in order to try and make them as concrete as possible. In terms of adaptations for physical health difficulties, we used a variety of different exercises and metaphors that could be selected depending on someone's needs. So some were more verbally based, and some were more physically based. And so therapists could kind of sort of choose which ones were most appropriate for their clients. And then in terms of therapeutic delivery, we kind of made sure the sessions were flexible with respect to the kind of material covered, the amount of material covered, so that people could go at a kind of slower pace where necessary. For us, we conducted a small in order to test out the acceptability and the feasibility of our intervention, and I'm just going to take you through this now. So in this study, we recruited people aged 65 and over with a diagnosis of treatment-resistant GAD, and we recruited people from primary and secondary care settings, and also a little bit by self-referral. People were offered up to 16 sessions of ACT, either in their own home or in the clinic, and this is delivered by clinical psychologists or CBT therapists. And because this was a feasibility study, the main things that we were interested in were feasibility as defined by recruitment and retention, and then acceptability as defined by session attendance and satisfaction with therapy. But we looked at a number of other outcomes too, including things like anxiety, worry, depression. And we conducted some qualitative interviews with people afterwards to see, so both older people with treatment-resistant GAD and therapists to see what they kind of thought of the intervention. So we received 81 referrals, 37 of whom consented and were eligible to participate, and 7 of whom dropped out for we lost follow-up for various different reasons. In terms of demographic characteristics at baseline, so people were aged 65 to 89 years, and the majority of people self-identified as female and white British. In terms of clinical characteristics, the mean GAD-7 score, it was kind of in the moderate severity range, but you can see that around sort of half people had were scoring in the moderate range, and around half scoring in the severe range. The majority of people self-reported having one or more comorbid psychiatric disorders, with the most common comorbid psychiatric disorder being depression, and then another form of anxiety disorder. And again, the majority of people were taking kinds of psychotropic medication, antidepressants, for example, for GAD. And the mean score on the MSE was in the normal range. We did have a cut-off of 25 on the MSE scores to ensure that we weren't including people with more moderate cognitive impairment, and obviously we excluded people with things like dementia as well. So in terms of our primary outcomes, we showed good feasibility with respect to recruitment and also retention, and we showed good acceptability in terms of session attendance and satisfaction with therapy. We also showed evidence of an improvement in scores on the geriatric anxiety inventory at 20 weeks, the geriatric depression scale, and the acceptance and action questionnaire, which is a measure of psychological inflexibility, which is what ACT aims to decrease. Now, it's important sort of to consider whether any of these kind of changes were reliable, so whether they were due to measurement error alone. And so we calculated the reliable change index for things like the geriatric anxiety inventory. And so we showed that just under half of participants had a reliable reduction in anxiety at follow-up. So as I mentioned earlier, the main aims of ACT, it's not focused on symptomatic reduction, but we do see that happening in therapy as a result of people taking steps to do things they really value and care about alongside the difficulties they're experiencing, and that's obviously what we see here. So turning to the strengths of the study, this was the first study to develop and evaluate a psychological intervention for older people with treatment-resistant GAD, and we showed kind of sort of sufficient evidence of that feasibility and acceptability. And we also showed that it was possible to train and supervise clinical psychologists and CBT therapists with very little experience of ACT to deliver the intervention with kind of sort of good fidelity. The main limitations, there was no control group because this was an uncontrolled feasibility study, and so of course we don't know whether that reduction in anxiety was due to people receiving ACT or due to things like people expecting ACT to be helpful for them. Obviously, it was because it was a feasibility study, it had a small sample size, so it wasn't sufficiently powered to kind of sort of examine clinical effectiveness. And the fact that participants, so we only recruited in the feasibility study, we only recruited people from Greater London, and also there are various different groups that were underrepresented, so people from ethnic minorities, men, and the older so people kind of sort of aged beyond 90, for example. These are underrepresented, and that just means you can't generalise those findings to a broader population. And that lack of outcome assessment beyond that 20 weeks means that we don't know whether any gains were maintained at follow-up. And so that's why we're now testing this out in a larger randomised controlled trial that's funded by the NIHR HTA programme and the Australian NHMRC. And the main aims of this trial really are to examine the clinical and cost effectiveness of ACT plus usual care in comparison to usual care alone for reducing anxiety in older people with treatment-resistant GAD. So in this trial, we're aiming to recruit 296 people with treatment-resistant GAD, so aged 60 and above. And we've currently recruited 203 people, so about sort of 2/3 of the way there. And again, we're recruiting people from primary and secondary care settings. And we're also recruiting from via self-referral at some of our sites through things like the NIHR's Be Part of Research and the Joint Dementia Research. There's obviously a lot of people without memory problems join dementia research as well. And this is, so we're recruiting people from the UK and Australia. And this map shows the 23 sites that we've got currently open around the UK, and obviously NSFT is one of our sites, which is one of the reasons why I'm coming to speak today. In terms of, people are chosen at random to have up to 14 sessions of ACT, plus then a booster session at 3 months post-intervention. So in addition to their kind of usual care, and that's compared to usual care alone. And people are able to have sessions in person, via video call, or via telephone. So it just depends what the kind of person's preferences are and what the therapist's availability is. In terms of the main thing we're interested in, it's the a measure of anxiety, the GAD-7, at 6 months. But we've got those other outcomes that we're interested in, including things like anxiety, depression, quality of life, and costs. And we're asking people to complete satisfaction questionnaires as well. So that's the CONTACT-GAD trial in a nutshell too. So just before I finish, just turning to a few resources in case you're interested in finding out more about any of the stuff I've talked about today. So if you want to find out more about any of our work, then the papers are listed here and they're all freely available. If you're interested in finding out a bit more about ACT, then you can watch some of these short videos. These are kind of sort of simple exercises and metaphors that are being created by the Veterans Health Administration in the US. So we haven't created them, and they're not being specifically designed for older people with treatment-resistant GAD, but it just gives you some ideas of those kind of core skills that are used in ACT. And another example is this free stress management guide booklet that's being published by the World Health Organization. That's based on ACT, and it's been translated into, the last count was 14 languages, and it's got accompanying audio files, so you can actually give that a go yourself if you're interested. In summary, GAD's the most common anxiety disorder in older people, but some people experience GAD that doesn't respond to current treatments. Unfortunately, we don't yet know the best way to manage treatment-resistant GAD in older people. So our small study, the factoid study, demonstrated kind of evidence of the feasibility and the acceptability of ACT for this population, and also showed that it might be helpful for reducing anxiety, and so that's why we're testing this out in a much larger clinical trial now. So before I finish, just want to say a huge thank you to everyone involved in the factoid and the CONTACT-GAD studies, and obviously thank you to the funders as well. And that's it. So thank you ever so much for listening, everybody. I'm just going to stop sharing my screen now.